Medicare has had this board in there, which was strictly that. MedPAC, it was an advisory board to Congress to say, hey, we've got some problems here with funding. Maybe we should look over here. Congress would then have the ability to make those decisions. What this IPAB did, the so-called IPAB, and I want to go fairly
slow. If the gentleman will yield just for a second, I would like to call my colleagues' attention to this poster, because this is exactly what Dr. Rowe, Mr. Speaker, is talking about now, this IPAB, Independent Patient Advisory Board. And I want all my colleagues to see this poster, because this is what Dr. Rowe has taken us through at this point. And I yield back to my colleague.
I thank the gentleman for yielding. And, Mr. Speaker, what I did when I read this, I looked at it and thought, how was this created and why was it created? Well, this board has 15 members that are appointed by the administration, by the president, and quite frankly, I don't want a Republican president or a Democratic president doing this. These people are then approved by the Senate for a 6-year term. They're paid about $165,000 a year. And what is their charge? Well, their charge is if Medicare spending hits certain targeted limits, that cuts occur first to providers and for prescription drugs, and then later to hospitals. Well, what worries me about this is right now we have a problem, and Dr. Paul Brown is here tonight, who's a primary care physician, with our patients seeing their Medicare, finding a physician to take care of them. And what happens is if you hit these targeted limits and physician payments are cut, access to care is going to be cut, quality of care is going to be cut, and thirdly, the cost to our seniors is going to go up. And what also worries me is that this board very much mimics the board that's in England called NICE, the National Institute of Clinical Excellence. And this board makes recommendations to their health board there about what care is provided to patients. President Obama has taken this board about, he's going to use this, and he actually wants to increase the power of it to help hold Medicare costs down. Ultimately, what will happen when you have more demand for services and you have money to pay for it is your care will be rationed. And that's the fear that we have. Our concern is, and I've gone to seniors in my district and been very clear and pointed this out at town hall meetings and have held town hall meetings with seniors and said, we want to provide you quality access of care. That's what I do as a doctor. That's what I want to be able to see those patients and have them help us solve this problem. And I think that's the issue that we have, Mr. Speaker, is how do we provide the care for the money we have and provide quality of care and access for our patients? And I am extremely concerned that the IPAB will do just the opposite of that. And I'll yield back to the gentleman now.
Well, I thank the gentleman very much for his presentation on the IPAD, that board which Dr. Rowe describes, Mr. Speaker, and my colleagues. And again, I'm going to refer back to a previous poster that I wanted to present as Dr. Rowe got into talking about the Democrats' solution to so-called save Medicare, they wanted initially to ignore the problem, the fact that Medicare is going broke. As I pointed out in my opening remarks, Medicare today will be broke in less than 10 years. Without action, the Social Security trustees report that Medicare seniors will either see a 22% benefit cut or workers will see a 22% hike in payroll taxes. So basically, not really completely ignoring the problem, but what the Democrats want to do is create this so-called IPAB board, which Dr. Rowe describes, and they say there will be no rationing, yet they're restricted in the recommendations that they can make in regard to cuts, and those cuts will be to providers, they will be to pharmaceutical companies that provide the drugs that so greatly keep people alive today, that in the past were ending up in the emergency room with strokes because of uncontrolled high blood pressure, needing amputations because of uncontrolled diabetes, or needing to be on a dialysis machine because of uncontrolled renal disease. All of these have been helped by Medicare Part D. So clearly, the plan that Obama administration and our Democratic colleagues have is not for saving Medicare. At this time, let me yield the floor to our colleague, my colleague from Georgia, fellow physician and member of the House GOP Doctors Caucus, Dr. Paul Brown.
Thank you, Dr. Gingrey. Appreciate you yielding a few minutes. I wanted to kind of break all this down so that the American people could understand very clearly what we're talking about tonight. I've got a little poster here that shows the Democrats, President Obama and the Democrats' Medicare solution. This is their Medicare plan. They deny the problem. They deny the problem that Dr. Gingrey, you were just talking about with this huge, huge problem where Medicare is going to go broke in a matter of just a decade. They want to delay any fixes. In fact, Medicare, as we know it today, exists no longer. Obamacare took care of that. And they want to destroy it. They will destroy it by letting it go broke. So this is the Democrat Party's health care plan. Deny it, delay it, and destroy it by letting it go broke. Just recently, one of the government accounting groups released something that should scare every senior, every taxpayer, every American. They said that Medicare within the next couple of decades, a lot of zeros in this, 63 and a lot of zeros. This is the unfunded liability of Medicare over just the next several decades.
Gentlemen, will yield. That will be $63 trillion, if I'm not mistaken.
I just try to make it so that the zeros didn't confuse folks. The unfunded liabilities for Medicare is $63 trillion. This is unsustainable. There's no way to take care of this. We need to shore up Medicare. We need to make sure that it's strengthened so that our future generations, not only the senior citizens today, can continue to get Medicare, but that future generations also. Now, what does $63 trillion of unfunded liabilities mean to everybody in this country? I mean, that's too big a number for everybody to really consider. So I broke it down to every family in the United States. Every family's part of this $63 trillion of unfunded liabilities for Medicare, as it exists today, is over $500,000 per family. $500,000 per family of unfunded liabilities for Medicare just in the next several decades. Now, I don't know about most families, but my family can't afford to pay $500,000, and neither can the government.
If the gentleman will yield
Absolutely.
back to me just for a second, and I've got a poster that points out just exactly what the gentleman from Georgia, Dr. Brown, is saying. The CBO, if you look, colleagues, at the bottom of this poster, CBO estimates individual and corporate income tax rates would have to rise by 90% through the year 2050 to finance Medicare and Medicaid. And if Medicare is not fixed, millions of workers today will lose the money that they have invested, and indeed they have invested with that payroll tax over those many years of their employment. And I yield back.
Well, thank you, Dr. Gingrey. What the American people need to understand is that we need to strengthen Medicare and Social Security for future generations. This picture right here is a picture of my two grandchildren, Tillman and Seal Surratt. I love these two kids greatly. They won't see Medicare. And they're going to see an America that's quite different from that we see today if we don't make some major changes in Medicare and Social Security. If we don't strengthen them and make them economically viable for my grandchildren that are 6 and 7. My grandchildren won't see Medicare. They won't see Social Security. And in fact, people who are 45 or 50 today won't see Social Security and Medicare if we don't strengthen them, if we don't do the necessary hard work of bringing about those changes to strengthening Medicare and Social Security to make them economically viable. I hear our Democrat colleagues all the time talk about it's the children. I've heard our former speakers talk about it's about the children so much that I wanted to throw up. But the thing is, when you talk about it's the children and their future, we've got to deal with this debt. We've got to deal with Social Security and Medicare and make them economically viable by strengthening them, by making them so that they're still available when my kids get grown. And we're going down the road right now, this president and the Democrats in the Senate, the Democrats here in the House, have a three-word plan. Their plan is a three-word plan for Social Security and Medicare. Deny the problem. They're denying it. They're delaying doing anything about it. And they're going to destroy it because both Medicare and Social Security are going broke if we don't strengthen it, if we don't make it economically viable, if we don't do the necessary hard work that this Congress and Republicans are trying to do. But what do we hear from our colleagues on the other side? Demagoguery. Demagoguery. And trying to play politics. It's time to stop the politics. It's time to stop playing games. The American people deserve the truth. No more accounting gimmicks. No more playing with numbers. No more double talk, political speak. This is the Democrats' plan. Deny it, delay it, destroy it for Medicare, Social Security, and this country economically. We've got to change it, and that's what Republicans are working very hard to do. I yield back.
Well, I thank Mr. Speaker. I thank the gentleman very much. And while we're on the D word, if you will, deny, delay, demagogue, I'll use another D word, and it's really the softest thing I can say about the Democrats' plan, and that is disingenuous. Disingenuous. For them to stand up, or for the President to stand up and say that he's going to fix Medicare. At the same time, Dr. Rowe talked about this early in the evening. I'm going to refer back to him in just a few minutes. But at the same time, in the creation of a whole new entitlement program in March of last year, we know it as Obamacare. Officially, I guess I should say, it's called Patient Protection and Affordable Care Act. I think it's the Unaffordable Care Act in that it cost $1 trillion. But where did the money come from to pay for this new entitlement program that really has nothing to do with seniors? Well, my colleagues, look at this poster to my left, your right. Here's where at least half of the money came from: cutting Medicare by $575 billion. I mean, right out of the Medicare program. That included home health care, it included hospice, but the biggest cut was $130 billion. That's bullet point number 2. $130 billion from the Medicare Advantage plans, and my colleagues know this, and I'm sure they'll want to comment on it. Of the 47 million people, 47 million people today who are on Medicare, about 7 to 10 million of them receive their medical care on the Medicare Advantage option, which gives them more benefits, more bang for the buck, and it covers a lot of preventive services that are not given, not offered in traditional Medicare as we know it. So that cut $130 billion, that's something like 14% cut out of that program. That means that at least half of these seniors are going to have to go back into Medicare as we know it and get a lesser benefit. In fact, it's been said it's been said by the actuary of Medicare, Richard Foster, on April the 22nd, 2010, that 15% of hospitals, nursing homes, and home health care providers will close because Medicare pays less under Obamacare.
The gentleman yields.
And I want to yield just briefly again to the gentleman from Georgia before I yield some additional time to my colleague, our co-chair of the House GOP, Dr. Skoskis, the gentleman from Pennsylvania. But I yield back to the gentleman from Georgia.
I thank you for yielding just a moment or two, because I want to add to that statistics. 15% of hospitals, nursing homes, and home health care will close because Medicare pays less under Obamacare. That's absolutely true. A lot of those hospitals are going to be in rural communities, because rural communities are going to be hit the hardest. Right now, I'm a primary care doctor, as the gentleman knows. I'm a family doctor. Done general medicine for almost 40 years now. The American Academy of Family Physicians said right now today, 1 in 8 family docs will not accept Medicare at all. Only 1 in 3 doctors, according to the American Medical Association, 1 in 3 doctors, according to the American Medical Association, limits how many Medicare patients that they take. That is a marked rise. Back in 2004, it was only 6% of primary care doctors, of all doctors, limited their Medicare patients. 2008, it went up to 8%. Now it's almost a third. Limit the amount of Medicare patients that they see. And 1 in 8 family docs don't take Medicare at all. They can't afford to, because of the low reimbursement rates, and IPAB is going to hit those folks that much harder. We said during our special orders when we were discussing Obamacare that I made a comment that somebody may have a free health care card in their pocket, but it's going to be as worthless as a Confederate dollar after the war between the states, because nobody will take it. And that's exactly where we're headed. So I just wanted to add that, and I'll yield back.
I thank the gentleman from Georgia. I now yield to my co-chair of the House GOP, Dr. Skoskis, the gentleman from Pennsylvania, Dr. Tim Murphy.
Thank you, Dr. Gingrey. I want to talk for about 5 minutes here on an issue that you brought up, Dr. Gingrey, about the $575 billion from the Medicare program that also cuts $135 billion from Medicare Advantage plans, forcing over 7 million seniors out of their current Medicare plan unless they pay more. And I want to help point out that while the President and others are out there saying we're trying to cut Medicare and what it does, nothing could be further from the truth. What we're trying to do here is show how if Medicare is handled differently, not by IPAB or a board of bureaucrats, but by letting the plans work and letting doctors work, they can drive down costs by improving quality. Let me explain what happened in the Medicare Advantage program that was gutted in the health care bill that was passed out of the House. Well, seniors are able to make choices right now with Medicare. They can get Medicare Part D drug coverage and supplemental Medigap policies, Medicare Advantage plan. What the Medicare Advantage plan does is allows some management of diseases as chronic illness, which is very different from the current fee-for-service where some may get paid based upon the number of procedures they do. When Medicare Advantage, under regular Medicare fee-for-service plan, hospital readmission rates, that's 30 days post-discharge for the country, in 2007, was over 18%. But the average readmission rate across Medicare Advantage was 13.5%. Why? Because it allowed physicians and nurses to talk to the patient, to follow the patient, to work with the disease, to make sure whatever complication they had, an infection or heart disease or lung disease or an orthopedic problem, to pay that physicians and staff to work for them. Here's another interesting thing. The Medicare fee-for-service rate of preventable emergency department visits was 15.5 visits per 100 beneficiary month in 2007. But the average rate across Medicare Advantage plans and study was 2 visits per 100 beneficiary months, 86% lower than Medicare's national average. Here's another point. Actual costs for the drug plan we know, and Medicare Part D, comes out 40% under budget because insurers are forced to compete with each other. Now imagine this. Seniors can choose Medicare supplemental plans, and those plans compete for seniors' coverage. The drug plans compete for seniors' coverage. What happens if seniors are allowed to also choose their main Medicare plan? Well, listen to this additional issue about drugs. The Intercontinental Marketing Services, IMS, and I should say this comes from the Deloitte & Touche website, the Institute for Healthcare Informatics study concluded the average cost for drugs frequently used by Medicare prescription drug Part D beneficiaries declined since the implementation of the program in 2006. Between January 2006 and December 2010, for the top 10 therapeutic classes, Part D drugs decreased by over a third, from $1.50 to $1. The study projected that costs will continue to decline by 57% from 2006 to 2015, reaching 65 cents by the end of 2015. That's a massive decline. Why? Because plans are competing against each other. Plans innovate. They try and do things better and smarter with better quality, and they ask seniors to choose their plan. Seniors then, by signing their name, can choose a plan that works for them. Why not allow seniors to have Medicare choice with their major Medicare plan? Why not allow seniors to have Medicare Advantage instead of gutting the program? This is the very thing we're saying. By improving efficiencies and qualities within the program, a lot of costs can be reduced. It can't be reduced, however, by the status quo. As you pointed out, Dr. Gingrey and my colleagues, keeping the status quo means there won't be Medicare. There will be Medicare for those currently on it. It won't be there for the children, and certainly not for their grandchildren. We want to save Medicare, but you can't save it by the continued way it's being done now. And quite frankly, the system that's being done out there now to frighten seniors, to say that if we don't simply pass this debt limit increase without strings attached, that seniors won't have Social Security or Medicare. This is such a falsehood, and it's a serious problem in two ways. One, it's serious because it's telling a falsehood to seniors. And two, it looks down upon seniors thinking that they're susceptible enough, not smart enough to figure out that this is false. It is so important, and we want the American public to understand we're trying to save Medicare because we do want it to be there for the future. But it means making it more efficient. And what's wrong with letting doctors be the ones that call the shots on improving care? And I yield back to the gentleman.
Well, Mr. Speaker, I appreciate so much the gentleman from Pennsylvania spent his professional life in providing medical services to his patients, just as so many of the doctors in the caucus. You know, talking about this cut to Medicare Advantage. And as Dr. Murphy described, that method of getting care, Mr. Speaker, is exactly what we continue to talk about today, of wanting to reward health care based on quality and not necessarily quantity. Just strictly fee-for-service, the number of times you go to see a provider, and that provider getting paid, albeit a small amount, it's not a very efficient way. And certainly a much more efficient way, and we continue to talk about this, is to provide quality of care. And Dr. Murphy correctly pointed out, Mr. Speaker, that's exactly what Medicare Advantage does. It offers a quality of care and a wellness provision. And, were we paying these plans a little too much for those services? I don't know, maybe, possibly. But if you're going to cut any amount, certainly 14%, $130 billion is too much, because that guts those plans. But whatever savings you get out of Medicare, shouldn't they stay in the Medicare program? If you believe the Medicare actuary and the trustees that say that if we don't do something by 2024, the trust fund, the hospital trust fund, is depleted. There is no more Medicare as we know it or in any other way. So if you're going to find savings in the Medicare program, you don't take that money, $575 billion, and use it to create a whole new, another entitlement program so that everybody in the whole country has health insurance, whether they need it or not, whether they want it or not. I can think of a lot of things in the Medicare program that could be where this money could be well spent. How about long-term care, extended care facility coverage to keep that money in Medicare? Instead, what Obamacare comes up with is something called the Class Act, which is a classless act, Mr. Speaker, because it is a misleading program that can't fund itself, that absolutely can't fund itself. So, you know, there's so many things about this Obamacare and Obama's plan to save Medicare, which really, as Dr. Brown pointed out, is no plan at all other than what Dr. Rowe has pointed out in regard to this Independent Payment Advisory Board that is going to cut spending for the most vulnerable seniors, those that are the sickest, those that incur the highest cost. And they say there's no rationing, but it will indeed, as my colleagues have pointed out, Mr. Speaker, be denial of care. And at this point, I would like to yield back to the gentleman from Tennessee to talk a little bit more about that.
I thank the gentleman for yielding. And, Mr. Speaker, I do want to point out one thing that Dr. Gingrey just pointed out, which was one of the reasons that the American people don't trust politicians. The Class Act may be a good idea. The Class Act began this year, where you have some money taken out of your paycheck and put in a savings account over here. And it's supposed to be about $87 billion in 5 years, and we can't get it out until that 5-year period of time occurs and this money is accumulated. And at that time, it's supposed to pay for long-term care, about $50 per day. But guess what happens, Mr. Speaker? What happens is that we borrow the money out and spend it on current health care and call this an asset and call this an asset. We've counted that money twice, 2 times. We've done that with Social Security already, and I find this absolutely offensive, is that when in August the 2nd, 10 days, whatever that is from now, about a week from now, we've had the audacity to tell people who paid into Social Security for 40 or 50 years that they're not going to be able to get their check. And why? Because the federal government has spent that money. And we're doing the same thing again with the Class Act. And there's already been legislation to perhaps overturn that. I want to get back just a moment to something a little more basic, and that's to the examining room with the patient. The people that should be making health care decisions should be a family, the patient, and their physician sitting around and talking about what their options are, not some 15 people appointed bureaucrats in Washington, D.C. We have, by the way, Dr. Gingrey and Mr. Speaker, we've had over 190 co-sponsors, including a bipartisan co-sponsorship to the repeal of IPAB, including every physician, every health care provider on the Republican side, and Dr. Christensen, who was down here just a moment ago on the Democratic side. It's a bipartisan agreement that we should overturn this. The American Medical Association believes it should be overturned. Over 270 major medical organizations see through this as a very bad thing for patients. And the reason that we're worried about it, and you've heard Dr. Brown speak about it, I've heard you speak about it, Mr. Speaker, is that ultimately it will affect the quality of care. Why? Because if you don't have access to your doctor, the quality of your care will go down. The other thing I want to mention right here is that we talk about changing Medicare. And quite frankly, I'm going to go through just a few of the things that Medicare has already been changed in this Affordable Care Act. Beginning in 2010, there were Medicare cuts to hospitals, long-term care, inpatient and rehabilitation services. In 2011, as has been pointed out already, the Medicare Advantage plans, the seniors did get a $250 check to fill the donut hole. The wealthier seniors began paying higher premiums for Medicare Part D. That's in 2011. Medicare imaging cuts, Medicare reimbursement cuts when seniors get a CT scan or an MRI. Medicare cuts for durable medical equipment began. Ambulance services, ambulatory surgery centers, diagnostic labs, durable medical equipment. Wheelchairs. Seniors prohibited from purchasing power wheelchairs unless they rent for 13 months. In 2012, next year, elimination of deduction for the employer expenses from Medicare drug subsidies. That's how they raised $4.5 billion. And, Mr. Speaker, that's not to improve our current underfunded Medicare plan. That's to create another entitlement. A medical expense deduction. You raise the threshold for deducting medical expenses from 7.5% to 10%. That raises $15 billion to be spent elsewhere. That's a tax right there. Hospice care is being cut. Dialysis, Medicare cuts to dialysis treatment will be cut in 2012. 2014, this Independent Payment Advisory Board begins. And by the way, they're getting, I believe it's $12 million a year to fund this right now. And if there's any way we can cut off funding to that board right now, it should be done. In 2015, a permanent cut to the payment rate for home health agencies. On and on. Already these cuts, we just haven't felt them because they haven't all come to fruition yet. What we're trying to do with Medicare is to salvage the program for future generations and not to. A promise made is a promise kept. If you're 55 and older with Social Security, Medicare, nothing happens. I hear all the time about a voucher. Vouchers being made, and this is a voucher system and so forth. Well, here's what a voucher is. A voucher is when I go to my mailbox and something comes that says, this has so much value. You take this piece of paper and you go purchase something with it. A premium support is where the federal government, through its massive ability to go out and negotiate prices, exactly like they do for you and me, Mr. Speaker, in our health care plan here in Congress, they negotiate with numerous companies through the Medicare, through the exchange, a federal exchange. Our plan's called the Federal Employees Health Benefit Plan. They negotiate the best price. And what happens is, all during the campaign, the last 2 years, I've heard seniors say and others say, Congressman, I want exactly what you have. And that's exactly what we're trying to do. A higher income senior like myself and you and the others in this room will pay a much higher premium. And folks with pre-existing conditions and lower income will pay much lower. And they will have those choices. As Dr. Murphy pointed out, why do we think that will save money and why are we doing it? It's been pointed out that it is a catastrophe waiting to happen if we do not do something. And with that, Dr. Gingrey, Mr. Speaker, I yield back.
Well, I thank you, Mr. Speaker. I thank the gentleman from Tennessee, Dr. Rowe, and what he was describing. If I could elaborate a little bit more on that point to our colleagues, because I think some still are confused, possibly on both sides of the aisle. But clearly, this plan that's put forth in the House budget, it's a Republican budget because we're in the majority. It's sometimes referred to as the Paul Ryan budget because he is chairman of the Budget Committee. It is sometimes referred to as a path to prosperity. But in that budget, which we sent to the Senate, and unfortunately the Senate Majority Leader has deep-sixed it, if you will, but in that budget plan, as Dr. Rowe was referring to, taken the responsible approach based on the trustees' estimate of Medicare program going totally broke by the year 2024, and that information is bipartisan. That's the Medicare Board of Trustees. To ignore that, as my colleague from Georgia said in his remarks, the D words, to defund, to deny, to what were some of the other ones, Dr. Brown? To deny, delay, destroy, demagogue, and I added to that those D words. Their plan is rather disingenuous. But what Dr. Rowe was describing is to protect and preserve Medicare as we know it, whether that's traditional Medicare or maybe we can salvage Medicare Advantage and hold harmless anybody that's that's over age 55 through 65. They're 10 years away from being eligible for a Medicare benefit. So they will be in those plans as we know it. But this approach that Dr. Rowe so adequately describes, Mr. Speaker, this premium support program, not a voucher, as he pointed out, the premium support program, which, by the way, would be administered by the Office of Personnel Management, the same folks that talk to us and find out what kind of health care benefit we want, those members who are under 65, that you pick and choose and you negotiate. They will do the same thing for future, those under age 55 today, future Medicare beneficiaries. They will get the best bang for the buck, the best care for their individual needs. Now, it's estimated that in 2022, that premium support amount, on average, will be $8,000 a year. Now, our Democratic friends, Mr. Speaker, want to say, well, that's not enough. That's not enough. Seniors are going to have to reach in their pocket. Well, what they don't tell you, Mr. Speaker, is that premium will be higher for anybody who comes into the Medicare program who's already sick, who already has several things wrong with them, and that certainly is possible. When I got Medicare eligible, I had already had open heart surgery. So these people will have a higher premium than the average of $8,000 a year. And as they age, even if their health is perfect the day they come into the Medicare, they become Medicare eligible, they may have the Methuselah gene and, Mr. Speaker, have wonderful health. Jog, 3 miles a day, don't smoke, don't drink excessively, don't skydive. But as they get older, then that premium support will automatically go up, because we know statistically that as you get older, the chances of something happening are greater. And last but not least, the higher your income, the lower your premium support. So that our seniors who need it the most will get a higher. They won't get the average $8,000. They will get a higher premium support. I think it's a wonderful plan, Mr. Speaker. I absolutely do. And it shows the responsibility of the majority party in this House of Representatives. And of course, as my colleagues have pointed out, what's the plan from the Democrats, from the Democrat majority in the Senate, and from this President? Deny it, delay it, destroy it, demagogue it, or as my colleague from Tennessee has pointed out, kill it by creating this independent payment advisory board, IPAB, which will, without question, lead to denial of care and rationing. And I yield back to my colleague from Tennessee.
Well, I thank the gentleman for yielding. And one of the things, Mr. Speaker, that I want to emphasize is that having no plan is a prescription for disaster for our country. We have a solemn obligation to provide health care for our seniors. We've made that promise. And how do we do it? And again, back to what I said, I do not want a board that is there, that's appointed by a Democrat, a Republican, or any bureaucrat. What I want is health care decisions made by physicians, the patient, and their family. And the way that's going to happen is through this plan where we use premium support to allow people choice and to have them make those choices, not insurance companies and certainly not the federal government. I mean, from what I have seen up here in my 2 terms is I don't want a bunch of federal bureaucrats in charge of my bypass operation or my gallbladder operation or my bunion operation, for that matter. I want my doctor in charge of it, and that's who I want making those decisions along with my family. I think this is one of the biggest discussions we will have in this Congress, is how we do this right. Not only does it affect the budget, and forget the budget, forget all that right now. We're talking about people's lives. We're talking about the care that they get. And right now, as I mentioned, these changes are already made. This is already in the current law that I talked about just a minute ago. When you talk about Medicare as it is, folks, it's been changed big time. And when this board kicks in, and there's a very good article, if you'd like to, if you are a sort of a wonk like I am, you want to go back to the New England Journal of Medicine, one of our major journals, in, I believe it was May of 2010. Their estimate was, this is one of our major scientific journals, that this IPAB board would have kicked in 21 of the last 25 years if it had been in place. So it's not some idle threat that this will happen. If you look retrospectively at what's happened, it would have happened 21 out of 25 times. And what would that mean? That would mean, as Dr. Brown, Mr. Speaker, pointed out just a moment ago, was as these payments for physicians go down and down and down below their cost of providing the care, they no longer can see you. You lose access to your doctors, like Dr. Brown.
If the gentleman would yield back to me just for a second, because what Dr. Rowe is talking about, Mr. Speaker, is on top of these cuts that our medical providers are currently facing under this so-called flawed formula sustainable growth rate, which I'm sure I'm correct on this, in the past 9 years, every calculation has been a cut to provider reimbursement to the point now that while we in Congress have had the ability to mitigate that, that if these cuts finally in the aggregate come due December the 31st of this year, it's a 30% cut. So we haven't solved that problem yet for our providers, but yet we're adding on top of that this IPAB board that can make additional cuts to provider reimbursement without any ability of the Congress, we the members of Congress, to stop that injustice. And I yield back to the gentleman.
A good point. Peter Orszag, who was the previous OMB director here, said this is one of the biggest losses of power that the Congress has given up since the Federal Reserve. And that's been almost 100 years ago. And what we're doing is that Congress takes 2/3 to overturn what they recommend in this IPAB. We could do it if we get a 2/3 vote. And it is not appealable. You don't have any appeal to a court system to do anything about this. So
the gentleman will yield, but we can overrule it with a 2/3 vote, but we still have to find cuts in the Medicare program somewhere else.
That's correct.
To the same dollar amount.
The gentleman is correct. What would happen is we can make those cuts, but they have to be made somewhere else. The cuts have to be made. And nowhere should Congress give up its ability to do that. Our House, the House side, are the representatives of the people. We're the closest to them. We have 700,000 constituents that we go talk to every time we get home, and we ought to be beholden to those folks in our districts across this country and not to some board up here in Congress that is not accountable to anybody. I yield back.
And I thank the gentleman. The gentleman from Georgia is kind enough to have stayed with us throughout the hour, and I'd like to yield back additional time to him if he would like.
Thank you, Dr. Gingrey. I'd certainly like the time. The American people need to understand that the purpose of Obamacare, the bottom line really was expressed by the President himself when he said he wanted everybody in this country in one pool. What's that mean for everybody? It means socialized medicine. And that's what all IPAB and all these cuts and everything is geared to do, is to force doctors out of private practice, make them employees of the federal government, make patients subject to some bureaucrat here in Washington and tell them what kind of health care that they can get. And the Democrats' plan is to deny, to delay, and to destroy Medicare by letting it go broke. But I want to just add, Dr. Gingrey, to your other D, the demagoguery that we see. I want to give 3 examples because the facts have really been, by and large, hidden from the American people. AARP did an ad, a new one, talking about all the places where the feds could cut spending, like treadmills for shrimp. Well, I certainly want to cut that out. But instead, Republicans insist on cutting seniors' Medicare. Well, that's not true. AARP and the Democrats want to cut Medicare by destroying it, letting it go broke. An ad put out by the Gender Project, a liberal nonprofit group, that shows an elderly woman being heaved off the side of a cliff, with her being in a wheelchair. It asks, is America beautiful without Medicare? Ask Paul Ryan and his friends in Congress. That's nothing but bald-faced lies, because we are trying to make sure that seniors get, as Dr. Rose said, a promise made, promise kept. We want to shore up Medicare and Social Security. We want to strengthen Medicare, not destroy it like the Democrats are going to do. Let me give you a third example, and then I'll yield back. On the Republican budget, President Obama said in a speech at George Washington University just last month, quote, says instead of guaranteed health care, you'll get a voucher. And if that voucher isn't worth enough to buy the insurance that's available in the open marketplace, well, tough luck, you're on your own. Put simply, it ends Medicare as we know it. End quote, President Obama. It's demagoguery. It's lies. Bald-faced lies designed to try to scare the American people, particularly senior citizens. We're trying to shore up Medicare. We're trying to strengthen Medicare. We're trying to save Medicare from going broke, but the Reid-Pelosi-Obama plan, Obamacare, is to deny it, to delay it, to destroy it, and to demagogue it.
The gentleman will yield back for a wrap-up. And as I said earlier, the kindest thing I can say is it's disingenuous. Stop the Democrats' plan to end Medicare. If left alone, the Democrats' Medicare cut plan created in Obamacare threatens Medicare seniors today, as well as those who will come into the program tomorrow. So, colleagues, how do we stop the Democrats' Medicare cut plan? First and foremost, we need to repeal Obamacare, but we need to vote and support Dr. Rose's bill to repeal this IPAB board and tell President Obama and Democrats that Medicare reform should not rely on restricting benefits and access for sick and disabled seniors in need. So as we conclude tonight, let me just say, colleagues, oppose the Democrats' Medicare cut board. Visit the GOP Doctors Caucus website and sign the online petition, Oppose the Democrats' Plan to Destroy Medicare. And here are the websites, doctorscaucus.gingrey, that's G-I-N-G-R-E-Y, .house.gov, or doctorscaucus.murphy.house.gov, the two co-chairs of the GOP House Doctors Caucus. Mr. Speaker, I thank our leadership for giving us an opportunity to bring to the American public, the American people, and to our colleagues on both sides of the aisle the true facts of this case, that we have a plan. The President has no plan, and I yield back.
The Chair would be pleased to entertain a motion. Gentleman from Georgia.
Mr. Chairman.
Gentleman from Georgia, recognized.
I do now. I move that the House do now adjourn.
The question is on the motion to adjourn. All those in favor say aye. Those opposed, no. The ayes have it. The motion is adopted. Accordingly, the House stands adjourned until 10 a.m. tomorrow for morning hour debate.
So the House is gavelled out, but earlier today, members began debate on 2012 Interior Department and Environmental Protection